where he has been a senior consultant urologist and uro-oncologist since the year 1995, a medical graduate and postgraduate from University of Delhi, a fellow of the Royal Colleges of Surgeons of Edinburgh and Glasgow, and the International Academy of Sciences. Last but not the least, he is a strong advocate of medical audits and culture of safety. Over to you, Dr. Subramanian.
Thank you. Namaste to all. You know, it is very interesting that when patients start getting better, when they heal, we always say they were nursed back to health. Whenever there is data which is circulated, which is very questionable, we say it is doctored data. So do you realize where we as doctors are considered vis-a-vis the nurses? You are the obvious healers. The nurses are the real healers. Let me begin by congratulating all of you on the 95th Military Nursing Services Racing Day. It's a very important hallmark for all of us to celebrate. As we celebrate the Year of the Nurse, commemorating the 200th birth anniversary of Florence Nightingale, let us remember that the nurses change the world every day. Not just the personal world of the patient, but the world at large. Huge skill sets, yet little spotlight. They constitute over 50% of the healthcare workforce and will account for 12% shortfall in workforce globally very soon. Supporting nursing is the only way to help boost the economy and gender equality. Modern nursing began in military hospitals. In 1865, the St. Stephen's Hospital in Delhi set up the first school of nursing, with the government hospital, Chennai, doing the same in 1871. And the TNAI was formed in 1908. 2020 will witness the culmination of the Nurses Now campaign, supported by Kate Middleton, focusing on the nurse's voice, the nursing workforce, research and leadership, and it will also result in release of the World Nursing Report. I just happened to look at some of the big names in the global nursing and realize how much they had done. When you look at Florence Nightingale, who in 1860 created the nursing school, she brought down mortality in hospitals by over a third, right at that time. She attached a lot of importance to the value of data. She was seen as one of the greatest heroes of the Crimean War. Look at Margaret Sanger. Margaret Sanger, working in the poorer parts of New York in 1900 and 1901, was the founder of Planned Parenthood. Clara Barton founded the American Red Cross during the Civil War. Virginia Henderson, called the foremost nurse of the century, she believed in restoring the independence and confidence in patients, and believed in reshaping and redefining nursing. Anna Caroline Maxwell, called the American Florence, played a significant role in the Spanish-American War. So you can see a lot of eminent people came into force and faced the challenges introduced by several wars and used those as opportunities to do well. So the adversity of these wars, which produced the finest leaders who changed the world. The current global crisis due to the Kobit, the pandemic which is impacting the entire world, bringing even the most resourceful of countries on their knees. I believe this is a time that great leaders in nursing will look at addressing those changes, which were probably long overdue. I'm a great believer in destiny. So all that I wished for when I said, I wish we have a great panel, and Bing dropped a few names. The names that were provided are of such a fine quality of leadership in nursing. If I just mentioned the names and said nothing else about them, I think at least people in the field of medicine and nursing would recognize them that way. But it's only fair that some who may not know them that well should be knowing a little more about them. So I'll briefly give you a little background of these speakers. So what I'll do is I will introduce one speaker at a time just before they spoke, so we are able to connect them with what they are able to say. There are three of them who are called captains. So they were not captains because of their title from the army. I think they are captains because they are the captains of the industry, because they are the leaders. So today, you and I are going to be really, really fortunate to get some real pearls of wisdom from these wonderful girls. So let me begin with Captain Usha Banerjee, the group nursing director for the entire Apollo group of hospitals, an alumnus of the College of Nursing, Armed Forces Medical College, Pune, commissioned into the military nursing services in 1989, took voluntary release on domestic grounds in 1996. She is bestowed with the President's Medal, Army Headquarter Medal, and many other coveted awards for academic excellence, first rank, and all-round outstanding student. She is also a recipient of many other national and international awards, including the Healthcare Management Asia Awards, FICCI Awards, National Women's Excellence Award, and the Rotary Club Delhi Central Award for Social Causes for Women and Children, just to name a few. I do have a few more of her achievements, and that is about 643 pages. I will leave those out. Holding other academic qualifications like an MBA, a diploma in hospital administration, a diploma in training and development, and certified courses in quality management system, Six Sigma and CRM, etc. Presently pursuing a PhD in management. That's what you call an unstoppable woman. We created a 14-inch thick concrete wall to stop her from running, but it did not stop her. So let me give you this wonderful, dynamic angel who we call Captain Usha Banerjee. Welcome, Usha.
Good afternoon. Respected Chairperson, Dr. Subramanian, eminent and distinguished members on the panel, nursing leaders, professionals, and my colleagues off the panel, members of the nursing fraternity, and members of the healthcare industry. It indeed is a great privilege and an honor for me to be here at the FICCI conference, and I thank the organizers for giving me this moment. I'm here to talk about leadership and change management before and beyond 2020. Leadership, as we all know, is a very, very complex subject, and there are multiple factors that decide and influence how successful a leader may or may not be. The interest in the psychology of leadership existed throughout human history, and it has grown over the last 100 years. Sociologists believe that leaders are a product of the society they live in. The genesis of great men and women have said that there are long series of social complex interactions that make a leader. And before the leader can influence change, society has to make them. Mythology and tradition made us believe that leaders are born and they're not made. The history of the world is but the biography of great men and women who we believe have had divine inspiration, the right man being born at the right time for a right cause, like the magical alchemy of the universe. India is a home to so many such remarkable, phenomenal men and women who have walked the earth. Then there is this theory that has made us believe that leadership is an inherent ability of the much learned and experienced people. Further, there was this theory that spoke about bloodline and the aristocratic nature of leadership and the social status, class, and educational levels. Management books and management schools have taught us various theories of leadership: the aristocratic, authoritative, democratic, laissez-faire, and all other styles of leadership. Today, we largely use the transactional style of leadership, which has got a clearly defined chain of command, control mechanisms, authority levels well defined, multiple hierarchies, a mechanism to reward and recognize people, a grievance redressal machinery, and also a punishment machinery. Well, ladies and gentlemen, I feel any model of leadership works well in a particular situation and a context and the meaning of the organization. And as long as it can create productivity and maximize efficiency, well, go ahead and use it. But today, there is a new paradigm in leadership. It's called the transformational leadership. It creates extraordinary outcomes and brings people together to achieve higher levels of efficiency. It talks about intellectual stimulation. It is all about idealized influence. It is about inspirational motivation. It is about individual consideration. It fosters challenge, enthusiasm, creativity, innovation, but with the backdrop of high ethical conduct. Today, the healthcare landscape is an example of a paradox. I say this with candid conviction. You may not like what I say, but that's the truth. Healthcare today perpetuates hierarchy, owing to its orthodox and paternalistic attitude, and is characterized by an unequal power base, which is largely tilting towards the powerful. However, I think change is just around the corner, and it has become evident that roles are shifting and boundaries are blurring. With vertical integration, diversification, emergence of large healthcare conglomerates, and blurring lines of demarcation, the need to change today is now more than ever. Safe healthcare and quality healthcare can never be provided in silos and with poor leadership. The legacy and history of the nursing profession is founded greatly with Florence Nightingale. Today, now, more than ever, nursing needs vibrant, dynamic, dedicated, and confident leaders. We are at a distinct advantage to influence healthcare legacy and advocacy, and nurses must pave the way to a different India. Many have become leaders by default, not by design. Today is the era of artificial intelligence, the big data, cloud computing, and talk about it, whatnot. Today, we are able to provide care with mathematical accuracy and robotic precision. But a change in nursing leadership is a must. There have been inexplicable failures and insurmountable obstacles and a profound dichotomy and a fearful silence from the nursing leaders to change the profession. And we are trapped in a myth. This country has not produced many leaders. It's far and few. And those who have done well for themselves have been change agents. They have worked very well for the reputation and reimbursement of the organization and the profession. Be expression of sheer terror with fiery temperaments, or mere people who will be subdued and manipulated. We have to become hallmarks of charisma and power in the right way, and a new breed of people must emerge, a new pedigree right from the bedside to the boardroom. It's an era of unprecedented pace of disruptive change. We need to change because it is a volatile, uncertain, complex, and ambiguous environment, and we must ride the wave of change. Personal styles are welcome, You could be subdued and analytical at times, or shout your manifestos from the mountaintops. Be a sensitive negotiator at the helm, or be a forceful authority. You need to have high degree of emotional intelligence and emotional quotient. Intellectual quotient is just a threshold, a basic entry level for leadership. Emotional intelligence is the sine qua non, indispensable feature of nursing leadership. It comes with persistence. It comes with practice. Today, the COVID-19 situation has put nurses on limelight. Nursing leadership has suddenly emerged like a phoenix. Well, exploit this opportunity. After all, it's the year of the nurse and declared by the World Health Organization. We need to set up our people for success. We need to combine extreme personal humility and an intense professional will. We must have an unwavering resolve to reject nepotism and rebuild our teams, adopt red flag mechanisms, and don't lament that the management does not include us in leadership roles. We must encourage creativity and entrepreneurship right at the bedside. We need to display a powerful mix of personal humility and an indomitable will. We need to set out with a ferocious resolve and a determination to do what has not been done so far. We need to be a semantic scholar who will collaborate and communicate. We need to have a compelling conviction with an obsessive optimism and a persuasive passion, because the right time has just arrived. There's no eureka moment. It's not going to be sudden. Leadership isn't mystical or mysterious, and it's not the province of the chosen few. Battle time has arrived. Today is the military nursing service raising day, 95 years of the Corps. And I use a military analogy that you cannot manage men in battle. You need to lead them. So go ahead and lead people. These deeply held beliefs we have carried so far will not stand good. They need to be challenged. The values that have made us successful so far will become less relevant in this multi-generational teams that we lead. We need an intense, pragmatic approach, a philosophical approach. And I wish that all the healthcare members, organizations, leaders, doctors, nurses must include nurses in nursing leadership roles and make them as critical resources so that we can achieve this ambition of National Rural Health Mission, Ayushman Bharat, Swasth Bharat, or the Arogya India that we talk about. This is what I bring to the table today, ladies and gentlemen. Over to the chair.
Thank you, Usha. I mean, you spoke like a true leader that you are. It's, the content of what you said was impressive, but the style of communication was that of a true leader. Not somebody who uses authority, but a genuine leader who knows the way, goes the way, and shows the way. So I think that is a tremendous part. Like you said, it's important to distinguish between a manager and a leader. And the leader that you are is exactly what you are trying to propound. We also know that the best results come from cooperation and collaborations. We all know the old saying from Ford, coming together is a beginning. Keeping together is progress. Working together is indeed success. We know that teamwork and collaboration are such wonderful things that they make the ordinary men and women achieve the extraordinary. To talk to us about the role of value of collaboration, I feel really excited introducing Thangam Gomez, Signia Healthcare, a president of the Association of Nurse Executives of India. For those who do not come from southern part of India, Thangam also means gold. Thangam, I think we really are looking forward to listen to you. but let me briefly introduce her. She has had a vibrant career of over 38 years, starting from bedside in India and abroad to being a group nursing head of the Fortis Healthcare Limited. She has spearheaded in setting nursing standards and quality assurance in Fortis. She is recognized as a skillful orator and is invited to conferences nationally and internationally. She has a keen interest in research and evidence-based practices. After donning several roles, Thangam has finally started her own venture, the Signia Healthcare, on the 1st of July 2020. The very young company believes in making a difference in healthcare through collaboration and with a special focus on nursing leadership development. She is dedicated to developing nurse leaders and strongly advocates that these leaders need to become nurse-centric to nurture young nurses to become patient-centric and develop into influential leaders of tomorrow. She is into consulting for several new hospitals, setting up nursing departments and simulation skill labs. Prior to that, Thangam headed clinical services at Arohan Healthcare Services. I can go on forever, but I'm sure it's more exciting to listen to Thangam. Over to you.
Thank you, Dr. Subramaniam. Thank you very much for that introduction. And good afternoon, everyone. Dr. Subramaniam, chair of the panel, and my esteemed co-panelist, and all the nursing fraternity, the leaders, the students, the staff, and all the other members of the healthcare industry. Very, very warm good afternoon. And I'm very grateful to FICCI for bringing this to the conference. And FICCI Heal has been always known to never overlook nursing. And this is a very apt example that, you know, this particular panel discussion is happening. And to follow Captain Usha Banerjee, and then all the other speakers after me, they are also captains. I am not a captain. That, you know, it is going to be very difficult to follow Dr. Subramaniam and Madam Usha Banerjee. They're so good with their words, and they are so effective in what they want to communicate. I think Usha has set the right tone of talking about the style of leadership that is required, that is transformational. So I am not going to talk to nurses again. I'm going to look at the role of collaboration and cooperation in achieving what we are desiring to achieve. The context that is set by Dr. Subramaniam and Captain Usha Banerjee, I'm going to deliberate on that. I'm going to use my presentation to help me with that. So just give me a second and I'm going to... Are you able to see my presentation?
Yes.
Okay. So this is now the FICCI Heal is about post-COVID healthcare, and the theme that we are discussing today is 2020 Year of the Nurse, Before and Beyond. And I think with my 38 years of experience in healthcare, I have experienced the before and now of it. Beyond is something that I would like to look forward. So I will try to set the context on the topic called collaboration and cooperation on a couple of thoughts on nurses globally. The nursing shortage is something that had been discussed for ages together, and we know that India is still running short of the prescribed minimum nurses per 1,000 population. And we know that we are trying hard to build up the number of nurses, and on top of that, we lose the nurses to other countries. And we know that for why is that we are losing them. Now, taking a note from the WHO's nursing report, it says that we had been short of 6.6 million nurses, and it has marginally dropped in 2018. And when we look out at 2030, we are hardly any better. So whatever that we are going to discuss, we know that to start with, the world is going to be very short of nurses, but very well connected. You can see this is the digital map of the world, and everywhere, everyone is connected to everybody else. So we know what else is happening everywhere else. But when you look at the scenario of nurses in the entire world, it says that we are going to be short of nurses, and the majority of the shortage will be in the low income and middle income countries, which includes our own country. So we have an urgent need to bridge the gap of the shortage of nurses. And we know that we will bring in more nurses and we are going to lose nurses to far developed countries. And for reasons, this is not the forum for me to discuss the reason, because that's not my topic, but all of us know why we lose the nurses. So there are urgent need to find that how do we attract nurses? How do we ensure they stay in the profession? How do we ensure that they give it back to the country and help the country to achieve the goals that the country has set out for the health of the nation? So the point of collaboration and cooperation, the terminology has been already discussed from day one. I heard Dr. Subramaniam during the inaugural session, so he used this word, collaboration and cooperation. And almost every senior person who has come and spoken on the inaugural day, there was a word, collaboration, cooperation, partnership. So it's very evident that unless and until we collaborate and cooperate, very little can be achieved. And that started with the quote from Dr. Subra that, the team, finally, working together is the challenge. So I'm going to just look at what is collaboration and cooperation. And I only want to talk about, I'm sure what is written there you can read. I'm not going to read that. The word I want to look at is that shared authorship. That is collaboration. Cooperation is when we are willing to reach out to each other. So when I look at collaboration, you are allowing somebody else to be part of the team, allowing the person to own the process or own the change. That is what is collaboration. So enough has been written about interprofessional practice by World Health Organization, Institute of Medicine. So a quick look at interprofessional practice, where multiple health workers, they come together to make a difference to patients, families, caregivers, and communities to deliver the highest quality of care. And I'm very sure it doesn't matter who is sitting in our audience today, each one of us in our role, what we do is to ensure that the best happens to the patient, the family, and the community. And we are sitting on a burden of communicable diseases, non-communicable diseases. Institute of Medicine in 2011, they looked at why this is required, because they knew that you cannot achieve the goals that are set for the health of the country without collaboration. So they started with advocating that accountability for workforce and health outcomes often is dispersed between academic health centers and healthcare networks. So there is this great connection between where the healthcare workers are being prepared and where the healthcare delivery is being done. But when it was studied later, also they found that it is still restricted to a single health profession. The education is still not interprofessional or a collaborative model. So the conclusion in that paper said that without a purposeful and more comprehensive system of engagement between education and healthcare delivery system, the things are not going to get better. And this I'm talking about primarily the study that was done in United States, not exactly in India. So then I looked at this World Nursing Report, which was released this year by WHO. So there also, they have validated that probably the only healthcare profession which is trained more in interprofessional collaboration is probably the nursing across the world. Now, I'm not going to look at all this. These are all, I have taken some sections from the same report. You can see that how many times the word collaboration is appearing over and over and over again. So I'm very sure that I have set the context for the need for collaboration and cooperation. So now I'm going to spend some time to discuss about where, when, and how. I have been in healthcare from 1977. I think that's when I joined nursing, and many of you in the audience may be not even born. From that time till now, I have seen various styles of collaboration and cooperation. I have been in systems where nurses were held at high esteem and they were made part of every single decision that was being taken. And I have also experienced systems where nursing decisions were taken without having a nurse on board. I cannot imagine whether any medical decisions will ever be taken in any forum without having a medical doctor present in that team. But many of us have experienced this, that many a times when decisions about nursing is being done, it was without a nursing representation. I would like to emphasize the fact that no one knows nursing better than nurses. So why not include them? We have got nurses who are highly educated, prepared for various specialties, public health, other specialties. We have nurses. They are just waiting to be included. They have enough wisdom to articulate what needs to be done from a strategic point of view. Many times the nurses are being just asked to do what has been decided in some forum. That's what I want to challenge today. If we continue to do that, Dr. Subra told in the beginning that if the nurses, they are the ones who really responsible for the healthcare delivery of the system and the country, and that has been proven over and over again. WHO, any good body, they will always tell that nurses are the only way to achieve the SDGs. So I'm going to summarize my certain thoughts on how collaboration and cooperation needs to be built. And I hope that everyone sitting in the audience and everyone from the private sector, the public sector, and especially from the government is paying heed to these deliberations which are happening today. And following me, Ajita is going to talk on policy, and finally Sandhya is going to put together everything. But let me just talk about collaboration and cooperation here. Education must be collaborative, and it was very heartening to see that the national education policy is thinking of making the first 1 or 2 years as a collaborative study. So that's a very good information. I heard it in another conference when one of the author of the NEP was mentioning that this is going to happen. So this is really something progressive which is going to happen. And I was a recipient of such an education way back in 1977. And I could see the difference in that organization because we all were together, working together. And let me tell you one more thing that I experienced where I studied. We had the same cafeteria for everyone. And I think that's a very outward gesture by any organization to say that everybody is at par, and it should be the respect that should be building up the entire team together. And there is an urgent need for collaboration and cooperation between academics and services. Very important. I'm very sure that the current nursing and midwifery council bill that is being prepared at the moment is going to look at this collaboration very closely, so that the healthcare givers who are getting trained, they actually become patient ready and industry ready by the time they come in. So services have to collaborate with the academics to ensure we are creating the right kind of skill set that is required to take care of the community and the health needs of the country and elsewhere. The practice, that's where the practice, whether it is in a hospital or in a public health or in any kind of setting, it has to be collaborative. It cannot be done in silos, decisions taken and then given it over to the nurses to follow without getting them involved. So even in a transformational leadership, what Usha told, the foundation of a transformational leadership, it goes by saying that go live among the people, understand what they want, and then make the decisions along with them. At the end of the day, when they achieve, they should say that we have done it. It is not that one particular domain or one particular person has achieved it. So that is practice. And definitely when it comes to problem solving and decision making, my humble request to everyone, especially the government, and when regulations are being made around nursing, it is very important to involve them. Believe me, we have enough talent and intelligence and EQ, IQ, EQ, and even social quotient is enough present in a lot of leaders. What you are seeing on this panel today is just a small glimpse of what is available out in the country. There are many, many more well-educated, well-trained nursing leaders in particular domains who can contribute to the country's plan for healthcare to achieve the SDG goals. So that's where the policy decisions, when they are being made, make sure the nurses are there in the table. Whether it is in a hospital or in a group hospitals or in a public sector or it is at government. I had been to government offices few times for some meetings, and sometimes I used to really feel very sad that we are discussing about nursing, and I used to represent not the government, I used to represent the body. But when I'm sitting there, I used to see the nursing leaders from the governmental sector who are supposed to be there were not part of that. The discussions and decisions are taken by administrative officers, doctors, and I think we are losing a great opportunity by not listening to the nurses and not including them. And I am sure that we are going to fall short of actions, because this is what Nurse Florence Nightingale told, that we can waste all our feelings in words, but they all need to be distilled into actions. And my humble request today is that let us invest in education, jobs, and leadership of nurses to ensure that we are able to achieve the universal health coverage and advance towards the SDGs. They are all very big goals set in front of us. And India is a very big country, and we need to involve nurses from all levels, from top to the last ASHA worker standing, giving that healthcare to the last mile. ASHA workers needs to be asked that what is it that is required to be done to the community. If you ask them, they will answer. So with that ASHA in mind, that our collaboration and cooperation will get better, I would say thank you very much to all of you for your patient listening. And if I have made a small nudge to the decision makers of the country, it will be great. We are just waiting to be called and to be involved so we can contribute to the best of the country's health. With that, I say thank you so much, and thanks to the chair and my panelists for patient listening. Thank you very much.
Thank you, Sangam. I think a very, very productive address, and I think you covered a very, very wide dimension. And I think this is very important, what you mentioned about the role of collaboration and cooperation and the value of inclusion. So it is not only about people in decision-making areas. So today in this program, I want every delegate, every participant to feel included, to be a part of our decision-making. So I would like each one of the delegates to make sure you participate in the poll. On your platform, you will sign a sign specifically indicating your questions are there, think about it, and definitely respond to the poll, because this way you will be a part of a decision-making process and the action that Tangam spoke about. Now, talking about inclusion, we say a more inclusive society always captures talent and ideas that resides in the margins. And simply having an attitude of inclusiveness and open-mindedness seems conducive to creativity. This I quote from Richard Florida, who is the Heinz Professor of Regional Economic Development at the Carnegie Mellon University. Now I have great pleasure in introducing our third speaker, who will be talking to us about the value of healthcare policy and inclusion. Ms. Ajita, who is the COO of the Abitus Institute of Medical Sciences. Ajita is the Chief Operating Officer at the Abitus Institute of Medical Sciences in Palakkad in Kerala, and an alumnus of the AFMC in Pune and the Christian Medical College, Vellore, and has 28 years of clinical, educational, and managerial experience, having worked at many premier institutes in armed forces, corporate, charitable trust healthcare organizations across the country. Ajita has been instrumental in many reforms in nursing. An accomplished teacher of nursing, she has served as a lecturer and a university examiner at Maharashtra University of Health Sciences and at IGNOU. She is specialized in commissioning of greenfield projects like the Fortis Memorial Research Institute, the Gurgaon and Maitra Hospital in Kozhikode. Ajita has successfully implemented cost-effective and sustainable strategies in hospital operations, patient management, and maintaining efficient workforce at the Ruby Hall Clinic in Pune and as the Aster Medicity, Kochi. So I want you to focus on what extensive knowledge Ajita brings to us while she addresses the value of healthcare policy and the value of inclusion in making these policies. Over to you, Ajita.
Thank you, sir. Good afternoon, ladies and gentlemen. We are today at a crossroad where, just a moment, let me share my screen.
Would you like us to share, or you're able to share?
Just let me try once. So I would be comfortable from here. Probably not able to share. Yes, you may.
Chetan, could you please switch it back to?
Thank you. Today we are talking about healthcare policy and inclusion of nurses as part of this talk on 2020, the year of nurse, beyond, before and beyond. Next slide, please. In order to understand the healthcare policy, we need to know the background of policy making and legal provisions as offered in the Constitution of India. Article 246 of the Constitution of India 1950, along with its 7th schedule, distributes the subject matters between the union and the states to legislate. Union here means the central government, and we have states and union territories. The 7th schedule provides for the union list on which the parliament is empowered to legislate upon, the state list in which the state legislature could draft law, and next one is the concurrent list on which is open, in fact, to both union and the state to legislate upon. We are talking about healthcare policy and the matter of public health and sanitation, which, as per the Constitution of India, is under the state list. Ladies and gentlemen, there is a lot of debate right now happening to shift this to the concurrent list, where the union will also be making the legislation with regard to public health and sanitation, though it is still under debate. The right to healthcare which guarantees protection of life and liberty. This structure is important to understand from where the legislation comes, and hence the legislation in healthcare. Next slide. Next slide, please. Coming to the public health of the states in India, which is as diverse as the country itself, as far as the prevalence of diseases, distribution of healthcare facilities, economic status, and the attitude towards health is concerned. Probably in the 1990s, by and large, the disease burden was due to communicable diseases and probably maternal and neonatal health. Almost 30 years down the line, a 2016 report says this showed a decline, which means that the communicable diseases definitely due to our center programs have declined, whereas non-communicable disease burden considerably has been increased, especially in southern states, which also has the health indices compatible or comparable with the developed countries. However, we have the Bimaru states, as it was known as once upon a time, like Uttar Pradesh, Chhattisgarh, Orissa, Rajasthan, maybe Madhya Pradesh, etc., still deal with a greater disease burden of the communicable diseases and child and maternal malnutrition related problems. This dichotomy or difference is described as states within the state. So each state in our country has its own problems, and probably a national legislation may not be able to address these problems appropriately for the states. So there is a dual challenge as well. Another bigger task for each state is its affordability, how much you are able to spend on healthcare. Next slide, please. Now, when we talk about healthcare policy and inclusion of the nurses, we need to know how much of legislation exists and how much more to be done. Of course, the dismal state of the affairs is not due to lack of legislation, but however, in health sector, to a greater extent, lack of legislation exists. Like say, for example, the public spending on healthcare. It is an abysmally low, less than 1.5% of the GDP, which in developed states or developed countries or the world average is 6% of the GDP. So which is abysmally low, and there need to be policy decisions on increase of budgetary expenditure on healthcare of the country. Investing in research and training, although the center assists in research and training and almost all the research institutions are under the control of the center, the states probably gets a very limited share of it. Another important aspect where legislation is required is probably disaster management. We need to have earmarked budget, as COVID-19 is not the only epidemic we are going to face. As it stands today, there may be many more like the COVID-19, which has caught us unguarded. There is an urgent need to establish a separate, probably long-term disaster management program with dedicated care centers across the country. We need to scale up public health services, number of beds, nurses, physicians, medical equipment, medicines, and care packages, etc. The state spending on this has to increase. Next, please. We need to make policies or legislation on workplace safety. The existing ones are not providing us as much of the safety as a workplace in a healthcare setting should provide. needless to say, about prevention of violence in healthcare, caring for the caregivers, and maybe technical advisory body for the states. As I said earlier, the states have very minimal resources, and technical advisory bodies in healthcare, almost all of them are under the control of the center, and hence the states are not able to contribute to them in terms of money, and hence their support to the states is very minimal. And probably what is the solution for the dynamic state of the states? Having technical advisory bodies specific to the states, which has the technical manpower in terms of maybe doctors, nurses, health, all others who work in healthcare represents. Also to say that, dealing with shortage of nurses, as Tangam has described it, a lot of nurses go away where we don't have enough nurses here. What is the center doing about it, or what is the states doing about it? Maybe as mute spectators. Unless and until enough spending happens in healthcare, the situation is going to be worsened. Education and training need to improve to deal with shortage of manpower in healthcare. Nursing practice is another area where a lot of legislation is required. What a nurse should do and what is under the purview of the nurse need to be defined by law, which does not exist today in our country. And this is one point where a lot of exploitation happens, and nurses end up doing a lot of things which require highest level of skills, but never get the credit for it. It is all because of absence of legislation. Financial aid to healthcare sector is another important area where legislation would help. Same like in education, if I may say. Education, we have educational institutions which work in private sector, but the salary of the teachers in schools is paid by the state government or the central government. We call them aided schools. Why should we not have aided hospitals? A part of the enormous healthcare spending in manpower budget or manpower expenditure, why the government does not share? Because providing healthcare is a government's responsibility, and a large chunk of healthcare today is provided by the healthcare sector, private healthcare sector. Hence, financial aid provided by the government would go a long way in ensuring appropriate healthcare accessibility and availability to the masses. Next, please. Next slide, please. Now we talk about where the nurse comes in all this. The nurse leader's voice is which should be heard. Nurse leaders at all levels, from ward to boardroom to international stage, need to be savvy about politics, policy, and power. I do understand that this is a controversial statement, that what will the people do if the nurses become savvy about politics, policy, and power? So far as the nurses were not, and probably that is one of the root causes of the problem. They should be at the top table in every health-related organization, and they should know how to make an impact in these challenging environments. Yet, the fact of the matter is that top nurses worldwide have very, very few opportunities to develop their policy-making competencies. One of the solutions probably for this is that the nursing organizations coming forward to pitch into the scene wherever the legislation happens. There is absolutely no point in complaining that someone else makes rules for us. The nurses in general and the nurse leaders in particular will have to pitch in wherever the policies are made, not only about the nurses, but also healthcare at large. Coalition with other professional bodies, as Tangam said, cooperation and collaboration with other professional bodies who are working in healthcare will give us a larger leverage probably. The pandemic, as quoted by Annette Kennedy, who is the president of International Council of Nurses, the pandemic has shown the world that the nurses' knowledge is essential to healthcare because of their unique relationship with patients, their families, and communities. Nurses have earned their place at the table whenever healthcare policy and planning decisions are being made. Nursing has been central to the response to COVID-19, and that is where it must stay as we look to the future and imagine what the new normal can and must be. Next slide, please. There are some action points in relation to what should the new normal be and what should the nurses do other than taking care of patients as we do every day. Implement effective human resource management in the context of COVID-19, which nevertheless goes without saying that supporting nurses, supporting all the healthcare workers who are fighting the pandemic. Unless we take care of the soldiers, they will run out of fuel soon. Support nursing and midwifery leadership at all levels of the healthcare system so that they'll be able to contribute to the healthcare policy development and decision making. Enable midwives and nurses to practice to the full extent of their education and training by updating relevant regulatory frameworks and providing appropriate workplace supports. It's been often discussed far and wide across all the stages that nurses do not have legit regulatory support in what they do. Even to give paracetamol to a patient with fever, they need a doctor's prescription. What usually happens at the bedside is the nurse goes behind a doctor, we search for a general duty medical officer in the bedside and make them to write, many a times force them to write the orders. That is because of the regulatory framework. High time to change this. Enable the midwives and nurses to practice to the full extent of their education and training. They have been trained, but they are unable to practice, or they need help for practicing it. Deploy and manage midwives and nurses to maximize their roles as bridges to the communities they serve. Increase investments in countries affected by shortages to educate, employ, and retain midwives and nurses. Probably many of our states in our country is in this stage where they are not able to retain their nurses, and we continue to suffer from the shortage of nurses, and there is not enough people to take care of the patients or who need healthcare, and rest everybody watches. This has to change, and there should be enough funding and there should be support which is offered from the center or state as the case may be. Next slide, please. So as I conclude, what I would like to bring to the table is that the government needs to invest in nursing and address the workforce issues that are holding their countries back. And they must ensure that decisions about healthcare policies make things better for nurses, support them in their work, and allow them to perform to their highest potential, whatever their field of expertise. Thank you.
Thank you, Ajita. I think that was an amazingly comprehensive delivery of such a wide-ranging subject, and which included such valuable points on legislation and the value of creating the best value healthcare. And thank you so much for it. You know, you've heard these wonderful ladies who have addressed such diverse dimension, but with a single focus to see that we are better tomorrow than we are today. Again, as Henry Ford said, if everyone is moving forward together, then success takes care of itself. So let me invite another very successful nursing leader who would share her thoughts on the way forward. I have great pleasure in inviting Captain Sandhya Pandey, Corporate Chief of Nursing, Pan Fortis Healthcare. Captain Sandhya is the Corporate Chief of Nursing, Pan India, Fortis Healthcare Limited. She has 24 years of contribution to military nursing, industrial and cooperative, and healthcare quality assurance. Previously, she was Director Nursing at Medanta Medicity and Group General Manager HR and Head Nursing Quality, Education and Training at Max Healthcare Limited. Her qualifications include RNRM, BSN, MSN, MBA in Healthcare Management, a PG Diploma in HRM, a Clinical Leadership training from the National University of Singapore. She's also held leadership roles in several associations related to nursing. Awards and recognition. National Healthcare Women Leadership Award by Z News and CMO Asia. Max India Chairman's Award in recognition of consistent, outstanding performance across Max India group of companies. The Chief of Army Staff Commendation Card for contribution towards Bhuj earthquake in 2002. General Officer in Command Commendation Card for leading the management of battle and trauma casualties during Kargil War at the 92nd Base Hospital, Srinagar. General Career Pass Medal for Best All-Rounder Outgoing Nursing Officer at the AFMC in 1998. I would love to go on, but it's nicer to invite Sandhya to come and share her thoughts. Come in, Sandhya.
Thank you, Dr. Subra. Thank you very much. That was indeed overwhelming. Just wanted to confirm if my screen is visible to everybody.
Yes.
All right. Thank you, Dr. Subra. Thank you very much. And a big hello and warm welcome to all my friends who have logged in here and are being with us this afternoon. It's actually encouraging and it's a matter of privilege to be sharing thoughts at this platform. And continuing the chain of thoughts from my previous speakers, my dear friends, I'll continue to bear the torch further. And of course, coming back to the focus of the topic and the talks here, we all know that pandemic will settle and we all will move on with immense learnings, mixed feelings, and probably emerge more connected, more empathetic, and more bonded within the hospitals or within the family, our own family, and within the community. But as we all know, and at multiple forums, the leaders had been talking that this pandemic has actually worked immensely towards creating an image makeover of nurses. But has it really cascaded to the bottom line, to the ground, in helping the nurses go more empowered? It has actually enabled the nurse leaders to position themselves more strongly in the society and attract the younger generation to opt for this profession? Has it happened? Or has it really worked towards strengthening the positioning of nurse leader in the decision-making forums? The answer is yet to be explored. It's, as this phase is not yet over, the answer is yet to be explored. And let's see this in the next few slides. And as we shift gears and the platforms like FICCI, which represent the industry, I draw everybody's attention on these 4 focus areas, which I'm going to stress upon. And Through this platform, I communicate and convey to each nurse who's logged in here and who'll be watching this talk and listening all ears. And these include primarily the nursing empowerment. These are all those areas which we now and again, every now and then, not only my frontline or my bedside nurse, my supervisor, my manager, everybody keeps talking, but primarily functioning and success of nursing revolve around these buckets. It's empowerment, it's their role in the policy creation and decision making. It's their level of preparedness in all aspects as a professional. And of course, do they really get the dues for the investments and efforts they make or not? So let's see. And as we talk of empowerments, the first and foremost thing which includes here is about leadership, because future of nursing depends on leadership. Yatha Raja Tatha Praja. We can't deny this age-old saying. And of course, the most important is leadership. And why, before coming on this platform, I did take some time to survey and interview a few of the leaders, nursing as well as non-nursing, and their clinician friends, as well as the leaders from the support services, to have their idea on what do they say. There were a few things which emerged in common, and I would like to share that finding with you, that there are some structural and feasible reasons, structural and functional reasons which challenge the feasibility of nurse leadership. And these factors include the low level of nursing representation in the national and the provincial level, the lack of representational body of the nursing profession for strong advocacy. There is actually the lack of clarity around the authority and accountability for decision making. If it is about manpower planning, is it the nursing head who's supposed to be planning the manpower for the hospital? Is it the patient care related products which are to be used on patient body, be it a DVT prophylaxis sleeve, be it a VT preventing gadget or a device, or be it a glucose monitoring device? Everything which be it a simple product or a simple aid like a draw sheet which acts as an absorbent of the secretions of a patient body, not leaving shear and friction and giving rise to pressure ulcers. So starting from the basics till the organizational level of major decisions, is there any clarity on who is the one who makes these decisions, and at to what level the nurse leader is involved in making these decisions for the organization? Of course, in our talks, we do say that there is nobody else who knows better than a nurse. But yes, of course, it's time to act on what I say and share this at this forum. And of course, more importantly, there is lack of role clarity at the larger level, at the larger picture between the state and the national level institutions, as in India, health isn't state subject. But this was about these structural factors which impact the, I would say, strengthening and evolving of nurse leadership. But functionally, there are many more aspects which impact the leadership. And here, when we say whether the nurse is able to make decisions or not, more importantly, was she prepared to take these decisions or not? In the beginning of this talk and in this series of discussions, Ms. Usha Banerjee has very clearly said, it's time to invest. Every leader is not born. They need to be prepared. They can be evolved and they can be carved and created from this workforce and the largest workforce of healthcare sector. It's time to prepare the leader. So it's one of the important factors which says whether the nurse is prepared to make these decisions or not. There is a matter of eligibility and, of course, lack of transparency in the processes which flow in the organizations. And of course, there is no mandate as on today with the top bodies in the country to be involved in other matters, that is the service sector, research sector, and the people management, the nursing workforce sector, apart from investing into the nursing education, which is immensely drawing the attention of all the key critical decision makers, all the key people and all the bodies at both state level and the national level. And so this was about the leadership which we talk. And if we visualize and envision today that empowerment in nursing will come from a strong and an amicable leadership. But what are the other things? Second is the decision making. Already spoke, but it's not about the decision making at the bedside. Decision making of the nurse by the nurses, involving her at all the level in the hospitals, both in both the sectors, be it the public sector or the private sectors, with the bedside nurses, the committees in the hospital, and of course, the senior management and ultimately the board. How many boards in the country as of today comprise a nurse being a part, taking strategic decisions for the entire organization? I'm yet to find one. And going back to my hospitals, say at least there should be 1/3 of the group in the decision-making teams as nurses from all levels, be it a nurse from a service sector, that is the bedside nursing, be it the nurse from the training or quality, infection control, or be it from a super specialty, be it from the leadership. But it should comprise of 1/3 of nurses to enable meticulous decisions where we don't fail and keep coming back and revising the page and filling the pages and creating versions and versions on. And we say of the critical congruence, there has to be parity and role-related designations and levels when we create hierarchy. Although there is a focus on creating competencies and skills for a particular designation or for a particular role in nursing. And this, I'm glad to see this is happening everywhere. Be it the induction, meticulous induction program, or the list of competencies listed by the Ministry of by the health section in the ministry, or in the private organizations where they are more robust in listing, not only defining but implementing and identifying the nurses with particular competencies. It's also the time to map both the competency skills and giving the level of to that nurse in the chain of hierarchy in the hospital. I'm not talking about in the nursing vertical. It is placing the nurse at parity within the organization so that she earns her empowerment and she exploits her competencies and skills which she is enriched with. Compensation and benefits. Of course, much about it is spoken, it's one of the areas which is caught up in the recent years in the country. And I'm glad to see there's a lot which is happening. I say, and it was nice to see the public sector paying more attention and focus and attracting the nurses from the private sector. And another, I would say, pleasing gesture, which was observed in the recent times, is attraction of the brighter nurses from the private sector to join the public sector. But of course, I'm glad that the talent remains within the country, and it has actually impacted the migration of the nurses as well. And when we talk of the visibility of the nurses, it's the visibility of the nurses, be it in the hospital, be it in the organization, be it in the institutes, doesn't come unless until the capability and the competency on the skill is demonstrated on ground. And here, when we say the intellectual bank of nursing rests in the institutions and college, I won't say the entire, but the majority of the intellectual bank, which rests in the nursing academic institutes. It's high time that we bridge this gap the way it's beautifully done in our clinician fraternity, where a professor, a consultant, a reader is very well involved in the bedside clinics, OPDs, and the patient care management. It's time when the capable nurses come to the hospitals. And this recommendation here would be through this platform that the postgraduate nurses who are super specialized, rich with knowledge, manage independent roles in the hospital. while managing their academic subjects with the institutes. All postgraduate programs should become residency programs, and thus there will be more of clinical exposure in the nurses. There will be more of confidence in the nurses in managing patients, and of course, by virtue of their exposure and expertise, and of course, the higher qualification and acquiring credentials, they'll be instrumental in imparting this knowledge and creating the leaders, creating confident nurses for the next generation. And when we talk of preparedness, we speak of leadership, and from there we spoke and we learned how prepared are we in proposing this and fighting this battle for the country, for the next generation of nurses tomorrow. Then it comes as technically, how sound are we? Are we really geared to create a leader? Are we really sensitized to have a young nurse with strong foundation to take charge and contribute to clinical decision makings at her patient bedside? Of course, there are CNE cells in the hospitals. There are training departments extensively seen in the private sector, in the corporate organizations, all hospitals and the accredited hospitals, where it is an instrumental part and the critical section in the hospital structure, in the hospital organogram. It's great to see that this is a very robust program and robust entity in the hospitals as on today. And there had been a tangential movement in focus and generating the focus towards training. But training and adding to the credit hours, and of course, having a survey on assessments on effectivity of training is not adequate. It is about converting that intent, converting the thought into action. And there where the CNE cells and the training departments are geared in building the capability for the nurses, let's have a more robust program focusing towards creating nurse leaders for tomorrow. That is the nursing leadership programs, which very eminent organizations has taken this task for building the nurses at the managerial level, supervisory level, and of course, carving leaders for tomorrow. This all starts from the new nurses who enter the organization in any sector. The stronger the foundation, the stronger the base, learning the practices and tricks of the trade, the stronger and safer is my patient and stronger becomes the domain. Not only this, that complete training trajectory and the developmental path being carved out with competencies mapped with the skills required for all the levels. Needless to say, the strongest and the only focused as on today, the infection prevention and control, which is actually domain of the nurses, driven by the nurses, probably the doers, the users, the beneficiary, and the advocates for the infection prevention and control today are the nurses. They are aided by and helped by the experts, the microbiologists, the other clinicians, the quality heads. It is time now the infection control nurses also become an integral part of decision making, not a data feeder for the committee and the and the entire team. And yes, redefining, relooking, and freezing on skills and competencies which we need for every level of nurse in the hierarchy. And what I want to bring out on these terminologies, everybody must be very familiar with. It is the time when we comprehensively look at the nurses domain or the nursing department in the hospitals, from the bedside nurses to the leaders, and having a foresight on the leaders of tomorrow, and through them, through the CNE cells and the training departments, building them eventually in due course of time. This is one thing, it's not limiting to the technical preparedness. This came as an most important need during this pandemic, thanks to COVID, which sensitized everybody on burnouts, which sensitized everybody on conflicts, conflict management, combating stress. And not only within the hospital, not only on the nurse or the healthcare worker, the doctor, the technician, the GDA, the housekeeping as an individual, but of course, the successful organizations in the pandemic today were the ones who were sensitive towards not only on the individuals, but also everybody who's connected with these individuals. And this came from the nurses who had small babies, who were lactating mothers, who have delivered in the recent months, and stressed, and of course had a lot to manage, not only at the hospital and not only in the COVID facility, not only COVID ICU or COVID ward, but on a larger side, managing the family and the relatives, managing their own societies and communities where they lived. Because had been instances where they were not permitted to enter their society, enter their homes, when people in the vicinity learned they had been caring for COVID positive patients in the COVID facility. And the organizations and the hospitals came forward in protecting them. So handling stress, it's not only once the COVID settles, this is something which actually is being identified as a very important need on being capable of handling stress, managing conflicts, intra-departmental and interdepartmental, and most importantly, uplifting and enhancing resilience. It's not about nurses, it's about our younger nurses. The younger nurses who are fresh from the college and comprise of the majority of the nursing workforce. Within the nursing workforce, the younger generation, and this is one I would urge through this platform to all the seniors to take as a responsibility to help the younger ones develop resilience. Of course, the third bucket, which I spoke of, was the policy creation and the decision making. And from the beginning, I say way back, there had been brains working, there had been cluster of people working, constitutions of committees have given their recommendations on reforms, on the change management, on the developmental aspects of nurses. It's high time we have a look. What I've quoted here are the key ones which have got one of the most powerful, suggested one of the most powerful building blocks for the nursing domain, which comes through the high power committee, which also is evident in the board committee recommendations, and of course in the 3 amendments and the critical amendments of the Indian Nursing Council Act, and primarily on the Code of Ethics. But just to put it in a nutshell, on these recommendations and the advisories on the nursing reformation, my suggestions and recommendations would stress upon an independent and a very highly supported and enabled nursing division in the ministry. I discourage the nursing roles coming on deputation of 2 years or 3 years, because India is such a vast, huge country, and with such a complex system of absurdity in the national and the state roles of the nursing bodies. We should have permanent positions and have people on deputation coming and aiding those positions from the multiple facilities and multiple sectors. Need to revamp, restructure, and relook into its constitution through its positioning, its pitching, and building it to enable to be more successful. And of course, having adequate nursing positions based on merit. Rather, this should have been unbold. The position should be based on merit. And here, this recommendations go strongly, and I talk about merit, reason being, when we talk of absurdity, lack of transparency, there is ambiguity, there is need for leadership, there is need for reformation, there is need for evolution, then probably we need the right people. It's actually the time we need the right people to take this in the right direction, and this has to be based on merit. I already spoke about the policy decisions, and I just reinforced through this that minimum of 1/3 of any decision-making team should be nurses. And I kept on looking forward on looking for the name of one nurse in the list of the decisions in when the guidelines were released, when the SOPs and protocols from the apex bodies were released, which actually gave directions to the country.
Sorry,
Sorry,
can
yes.
I conclude?
Yes. And I'm on verge of finishing. Thank you very much. And equal growth on all the 4 sectors, because this is one thing which lays the foundation for the growth of the organization. When we say growth of the sector, equal focus on nursing education, service sector, public health, and midwifery. And there can be 4 sub-verticals in the nursing domain. And last but not the least, as I said in my first slide, do we really get the dues of what we invest and the efforts we make? In last 73 years since independence, there had been 2 nurses who were decorated with the Apex Awards in the country. It's time we again urge and propose through that the nurses be considered and to be encouraged and recognized for their works and to be included in the list of the key awards and the premier awards in the country. And of course, some more benefits associated with the only national and recognized and the most, I would say, premier award, the Florence Nightingale Award, being conferred for the nurses today. And to be equally and extensively opened for the nurses in the private sector. And with this, I thank everybody by saying that individually we might be very strong, but together we are powerful. Thank you very much. Over to you, Dr. Subra. Thank you very much.
Yeah. An amazing insight into the way forward. And, it's outstanding. See, now I'm really delighted to announce the results of the poll. These are important questions. The first question was whether nursing gets full cooperation. Sorry, can I just, sorry, give me a moment. I think the questions which included whether the nurses were getting full cooperation from the other departments, and the answer was only 25% said yes, meaning that 75% thought that they did not get the kind of cooperation that they deserved. Second was in terms of the nursing opportunities. Again, most people felt at this point in time, 75% of them felt it was inadequate. The question of whether the nursing leadership needs a change, 75% of them thought it needs a change. The question on whether it should be transactional to transformational, 75% thought it should change, and only 13% thought it need not change. The last question was the format from dictatorship to democracy. Again, everybody felt, 75% felt it should change towards democracy. Now, we have some amazing questions which could elicit some brilliant answers. But today, what we found was our speakers were so comprehensive, so complete in what they had to say. They covered such depths in every specialty area that we were planning to do, that while seeking those solutions and clarity, we forgot that we've got a spoil sport called the clock. The clock just went ting. So our time is up. So it's time for me to just thank each one of you for the absolute angels that you have been, for the wonderful leaders that you have been, with such immense clarity in your expressions, such clear understanding of where nursing needs to go in terms of quality healthcare, in terms of research, in terms of learning. So I think integrating teaching, research, and clinical excellence, getting the collaborations with the right kind of cooperation, the appropriate legislations, the appropriate inclusivity, enhancing the role of the nurse into the nurse specialists, and most importantly, create greater leaders in healthcare from the nursing fraternity. I can't thank you all enough, but I'm sure this forum certainly helps us understand with a considerable amount of depth the role each of you has played in nursing leadership and the role each of you will play in healthcare delivery to the nation. So on behalf of the FICCI's HEAL organizing team, let me congratulate and thank each one of you. And let me thank the Secretariat of the FICCI for coordinating all the activities with such immense clarity and for the opportunity to be a part of this event. My pleasure interacting with four of these charming ladies, the charming leaders of the nursing world. Thank you and good afternoon. Namaste.
The primary objective of the vaccine that you find a different antigen, different target sites. So the different companies are making vaccine from different sources, different adjuvant, and everybody is trying to have the efficacious and safety vaccine. So the two important things, one is the efficacy, and the DCGI has already set a standard that at least it has to be 50% efficacious. Then comes the safety. And once that, and it is very good that people are working day and night on this, and we have reached to a clinical phase 2. Most of the companies are now phase 2. And I think that all the speakers will give the details of that. And then it will go into the phase 3, and hopefully, I'm not giving any specific date because it's very dangerous to give any specific date, because there are certain critical issues which a vaccine has to meet, particularly safety aspects and the dose calculation aspect. What the challenges would come after that, for which the government of India is already preparing, and I am part of that, is that adequacy in the number of vaccine for meeting each and every population of the country. That is one. Number two, the disposal or transportation of this vaccine safely and adequately, and then distribution and implementation, vaccination of the large population, followed by the follow-up, effective follow-up for the safety. And these, and of course the drug interaction and all those things. This is a huge and a challenge for which government is gearing up every day. We are having a meeting how to strategize the, so vaccine, effective vaccine development is one, then the effective adequate production is 2, number 3 is the adequate transportation and then vaccination to the public is the next, and the post-vaccine follow-up of this is the next one, and the last would be how to forecast the effectiveness of the antibody present. That means whether it will affect for 6 months, 1 year, or more than then. And challenge would be how possibility of the mutation of this coronavirus to some other, whether how we are prepared for that situation. So these are the challenges, but I am sure our such a wonderful experts, Dr. Arun and Aviral and my colleague and my good friend Madhur and Dr. Khoraiki Wala. I am not able to see him on the, and of course Sharad, always very dynamic and active. I can see you, Sharad, here, and nice to see you here, and of course you. So over to you.
Thank you, sir. So I think it's very interesting. You raise some very, very pertinent points. And as I said, one of the things which probably, sir, I would be very keen and interested to ask is, you rightly pointed out distribution. So there are, as you are aware, I mean, we all are aware that, probably the way the testing happened in the country, it was more public driven initially, but when the masses or the access need to be developed, we had to rope in the private sector. So is there the government thinking about how is the government planning the distribution? Is it purely government driven in the initial few months, later on probably roping in the private sector? Or what are the thoughts there, sir?
I think this is something which is being evolved gradually, and we have to strategize that. And we have not yet officially announced the strategy, but I would say the first would be those at a higher risk, maybe the healthcare worker or maybe like that, because they are the high risk, and then you go to the other categories A, B, C, D. And that would be, and therefore it has to be very strategically driven, because you will have less number of vaccine, more number of people will be requiring that, and therefore that has to be very, even it may require security, it may require pilferage, it may require, what we are also looking for, can we have a system by which each and every vaccine is accounted for, a written and document, and they trace back, so that it will have to have an AEFI immunization after the adverse event after immunization or after vaccination. That has to be very strong, and then online assessment of the post-vaccine safety period, that is also important. So it is going to be a marathon. It is going to be a massive task. And for that, not from the health secretary to the district nodal person, everybody has to be geared up. And that is what vaccine production is one aspect. But beyond that, it is again a very, very important aspect involving the district collector and involving the district health authorities and IT involvement. This is all, I think the government is gearing up for much larger task than what it appears from outside.
Amazing, sir. So one more question which I wanted to raise with you before I move on to the next panelist is, we also heard Department of Biotechnology saying that they are promoting or supporting almost 30 other odd candidates which will be used for COVID. Could you just throw some light there, sir?
See, the Department of Biotechnology is definitely interested in creating infrastructure so that we not only have the vaccine of corona today, self-sufficient in the country, but also a platform technology developed for if anything has to have a mutation, and then what can be done. So not only that, the like Indian National Institute of Immunology, what is called as NII, and I happen to governing body member of that, they are also developing a vaccine which is from this protein based, of course not yet gone into the clinical trial, but it is also a promising, and therefore such other candidates are also being worked out at different places. They have also asked for the call for proposals, those who are interested in developing vaccine with the vaccine can be developed by the different sources. But these are the pharmaceutical companies, 5 pharmaceutical, which have an experience, which have and data, which have already gone much ahead. So they are basically our hope. But our preparedness should have larger than what we have. So that is the objective of the Department of Biotechnology.
Thank you very much, sir. Moving on to Dr. Wadhwa, because I'll pick up what Dr. Y.K. Gupta sir has actually stated is about efficacy and about safety. So Dr. Wadhwa, you being a pediatrician, do you foresee that these vaccines, the initial vaccines which are being developed, what Dr. Gupta has just mentioned a long list of manufacturers, do you think that these vaccines will be as safe and efficacious as the proven vaccine which is currently available for children?
Yeah, thank you for calling me. I wanted to take up from where Dr. Gupta was talking about. The ultimate aim worldwide is seeing that, if suppose the virus mutates, or if we feel that the disease ends before the vaccine comes, everybody's got herd immunity. So we should finally develop a platform, because these are all new platforms. So we should develop a vaccine which will take care of a general coronavirus vaccine. So if there is SARS, MERS, SARS-CoV-3, SARS-CoV-4, whatever happens, we should be ready with a platform which is ready to manufacture vaccines as a short notice, and it will take care of all coronaviruses, not only mutations of SARS-CoV-2. So that's the ultimate aim, and if we humans can do it within the next 4-5 years, it will be a great thing. And so many bodies are doing that. CEPI is there, Gavi, PATH, they are all working on a universal coronavirus vaccine. So regarding this question of yours specifically, it's very difficult to say whether these vaccines will be as good as the prevalent vaccines or not, but most likely not. And why so? Because these are all absolutely new platforms. The messenger RNA adenovirus platform, the DNA technology, the plasmid DNA technology. So only one of them has been tried till now, which is the adenovirus vaccine, which is there for Ebola. And this Ebola vaccine also came after 5 years. So we are now looking at some vaccine which is coming within a year, less than a year. And these all are new platforms. So that is why they've said anything above 50 is fine, anything above 70 will be very good. The other vaccines, what we have now, the worst is BCG, which is 60%, which is actually not really a vaccine used worldwide, but typhoid vaccine is also 80%, and we are very happy with 80%. The rest are all 95, 97%, hepatitis B, measles, MMR. So, we are comparing with the vaccine, which is 95, 97% effective, to a vaccine here, because now first thing would be to reduce the mortality. So even if it is 50, 60%, if we can reduce the mortality, I think we've done a major thing. People don't mind falling sick, but obviously nobody wants to lose somebody near and dear one because of a viral illness. So we don't expect it to be as good, but even 50% plus should be good enough.
Great. So that brings me to the second
platforms. Nobody can say, really.
Correct, sir. Now, so building on that same thing, what has been the stats in children? I mean, since being a practicing pediatrician, how have you seen the stats within children? And do you foresee, because with all of the concerns raised around the vaccination being safe, a new platform, do you foresee that children should become the first part who should be receiving the vaccine, or should they come the last in the ladder?
Actually, that's a very interesting question, because both are linked. Statistically, children, we were always thinking that they are very mild illnesses. We've seen very mild illnesses. We see almost 5, 10 every day. And it's the grandparents who are suffering the maximum. Parents are a little better off, and children are very much better off. So most of the time, parents call us that, we are feeling so weak, so miserable, we can't get up from our bed. And our child is running around. We can't run after him. We are feeling so tired. He's feeling fine. What should we do? So children are generally falling sick less often. They are getting better faster. And we were thinking that they were not falling sick, but what is probably happening is they are falling sick, but they're not showing symptoms. So they are spreading. So if they are spreaders, they should ideally be given the vaccine first, because they are not falling sick. They are spreading to others, especially the grandparents. But unfortunately, that will not happen. Because all these vaccines are first tried in the adult population, which is the healthy adult population, 18 to 45 years.
Amazing.
And they would try to adults, because they are the target groups. Above 65 is a target group, major target group. And they would try to comorbid conditions. So all these companies are, testing phase 3 trials in 30,000 people. So out of 30,000, 10, 14,000 they've reserved for these people who are elderly, who are comorbid. And maximum they've gone is 5 years. But most of them are testing 14 to 18 years, 16 to 18 years, like not really real children. So once they have tested on adults, then senior citizens, then they'll come back to children. And unless it is tested in children, we can't give it to them. So as I foresee, they'll be the last ones to get.
Now, great. I think that's a great recommendation coming from a pediatrician like you, because that eases out the job of the Indian government when they are looking at the distribution part of the vaccine. So just building on this question, because then I will also use this. First, I'll take your views, and then I'll go to Dr. Aviral Roy for his views. This is about when you say that children will be the last in the whole scheme of, or grand scheme of things, when the vaccine is to be administered. Largely, if you see, our country has always the vaccination, be it Indradhanush or any other program, has been children driven. So one of the things which Dr. Y.K. Gupta sir was referring to was about the distribution. And now we are in a position where it is all about adult vaccination and on a mass scale. So there are two challenges which I know probably I would want to ask an expert like you, because we cannot stop the new births, the 25 million capacity or the new births which is happening in the country. We cannot do away with it. But how do you foresee the challenge of creating this network of adult immunization in the country with COVID?
That's for me.
So how do you see, how does India go about building adult vaccination?
If it actually succeeds as a mass immunization program, it will be the largest immunization program taken ever in our history of Earth. And we've had children programs like Pulse Polio, we've had MR programs, but never for adults. So for adults, it has to be really first time it will happen. And like he said, it has to be linked to something. And most likely, I think it will be linked to our Aadhaar card. Otherwise, there'll be people with connections taking it, people who don't actually need it, people who already had the disease. So it has to be, and it's going to be a tough job because there is no adult data. There's no way you can actually filter out people as adults who to give, who not to give. So there has to be a very strict guideline and monitoring.
So true. So thank you, Dr. Vadva, for those comments. And then I now look to Dr. Aviral Roy. The question stands the same, sir. Adult immunization, this becomes the largest ever. So I think in India, whatever we do for the masses will always be considered as the largest. So Ayushman Bharat scheme, the largest universal healthcare coverage scheme. So Dr. Roy, what are your thoughts about India promoting adult immunization for COVID? And this is not a one time, as rightly said by Dr. Y.K. Gupta, that this is something which we are seeing ongoing. The virus will keep mutating. So this may not be just one wonder vaccine immunization program. So what are your thoughts being a physician, sir?
Dr. Ajay, hi. First of all, am I audible?
You are loud and clear.
Perfect. Okay. So I'm many questions and many thoughts. Let us just start out by saying vaccinations are probably the defining invention, and probably if there's ever a Nobel Peace Prize that's not been given, it is for the invention of the vaccine, right? It is the single most invention that has reduced the mortality. We have eliminated disease and saved hundreds of millions, if not billions of lives with vaccines, right? Now, at the same time, you're currently dealing with a crisis which actually makes World War I and II look like peanuts. They were massive events in our history. Yes, but this is the only one. World War II, maybe 15 countries, 20 countries, 30 countries. This is 186 regions across the world. Forget India. This will be the largest, most massive immunization effort in the globe, at a scale and a level of cooperation never ever seen. This is the one. It is sad that you need a disaster like this to bring the entire world together, but that is where we are.
Yeah. So, Dr. Roy, I think in that context, my next question to you is, as you have seen the top four vaccine global companies, which is Pfizer, Moderna, Johnson & Johnson, and of course AstraZeneca as well, they have gone ahead and released the design protocols of their trials. Did you get a chance to look at them, and any suggestions which you, after reading those protocols, it makes you confident about the vaccine, it makes you confident about the platform? Because the presenters or the panelists before you have expressed concerns on safety and efficacy being the topmost two concerns.
So, as my distinguished colleagues have said, and Dr. Gupta also said, this is the first time we are making a vaccine for this virus, and this is the first time they're ever deploying one of these platforms, right? Like the mRNA platform has never really been deployed. So yes, there are some levels of, and like as just now mentioned, we are looking at efficacy levels of 50% or 60%, but that might be okay. There's a thought that, what, we can just let the virus spread and let herd immunity get through. That is really not an option for us, because we only see the mortality, but nobody sees, as a physician, we have such significant morbidity which is not being reported. People who get it, people who are persistently sick, they're 2 months out, 3 months out, unable to walk, unable to take deep breaths, unable to go back to the regular jobs. People who are going on the ventilator, survivors who are basically crippled for life from their lung issues, severe encephalitis, severe muscle loss, severe inability to move. So, we have no other choice. That being said, let's understand this. All the pharmaceutical companies are under significant media and regulator scrutiny. And these are massive trials. You're rolling out a vaccine with 30,000, 40,000, 60,000 people in a matter of 6 months. So I have very high level. Yes, there are concerns, but do I have a choice? Would I rather let my patient get COVID-19 and roll the dice on, maybe them dying or being stuck in a place where they may not recover fully? Or would I rather, or if I can prove that the vaccine is sufficiently safe, and there's a 50% chance that I can prevent them from getting disease. Would I take that or not?
So what I gather from you is that that's a great step of these four companies, making sure that, how much more transparent can you be, because these are testing times. And this being a new platform, as pointed out by Dr. Wadhwa as well, do you think that even Indian companies should follow suit and start releasing their protocols as well?
I agree. So we should, because at the end of the day, what do the numbers do? They basically tell you how likely it is you're going to pick up rare side effects. In your initial trial of 200 people, 300 people, you pick up common stuff. But the rare side effects that we really don't talk about, you need these large numbers, and you need a long-term follow-up, 2 years, 3 years, 4 years, but you're not really going to get there. Also, the large numbers also allow you to, your people need to get coronavirus, right? That's the only realistic way you're going to know if your vaccine works or not. So these things actually do work for me, and I think India should be doing it as well, because how are you going to compare if you don't know what the numbers are? So you should, and how have you done your study?
Amazing. Thank you so much, Dr. Roy. And now then I look forward to, as rightly pointed by Dr. Gupta, to another Dr. Gupta. So Madhur, I believe you have a presentation to share with all of us. So let's start with the presentation, and then I'll jump into my questions.
All right. Very good afternoon, everyone. Thank you to FICCI for very timely organizing this vaccine session. I'll just start to share my screen, and please let me know if you can see the presentation. Can you see the presentation?
Not yet.
Let me try again.
Yep, now we are.
See it coming up? Yeah.
Yes, we are.
So you can see it full screen, I hope.
Yeah, we can see full screen.
All right. So just to give you a glimpse of what WHO has been doing in this whole area since WHO had declared the pandemic as a public health emergency many, many months ago. So there are various areas in which WHO has been engaged, right from preclinical stages to the clinical trial phases in humans, and then to licensure and post-licensure. You can see that across the entire life cycle of development of the vaccine, whether it is releasing the landscape of COVID candidate vaccines on a periodic basis, which is periodically done and updated every week or so, criteria for the candidate vaccines prioritization, developing a target product profile for a potential COVID-19 vaccine, the preclinical assays, constituting networks and groups to work on these animal models and assays. And our Department of Biotechnology institutions, Translational Health Science and Technology Institute, is actually collaborating very closely on the assays and the animal models front with WHO to take this profile of the vaccines forward, especially for the COVAX facility vaccines, which we are going to see in the subsequent slides. So all across, whether it's from preclinical to post-licensure, the guidance and working on all the aspects. The WHO Solidarity Vaccine Trial has been launched. And this is basically to get multiple trials, basically candidates, to prioritize them, and many, many platforms, as the earlier speakers were alluding to, the virus vaccines, the new platforms being tried for the first time, the DNA, RNA vaccines, the protein-based vaccines. So just to get everybody to have a large number, sample size of the trial subjects, WHO has launched this trial, and with the interest expressed already from about 100 countries. The draft landscape is updated almost every week or so. And currently, as you can see, we have about 149 candidates in the preclinical phases of the trials globally. And in the clinical phase, there are about 38 candidates. 9 potential vaccine candidates are in phase 3 trials currently globally. And so that brings us, to close to 187 to 190 candidates, which WHO is tracking on a weekly basis. And as you know, that ICMR has launched their vaccine portal 2 days ago. And the vaccines data for global data for vaccines development, it is the WHO's draft landscape of COVID-19 candidate vaccines that is hyperlinked to the ICMR's portal. So it is going directly to the WHO portal if you click on that. Coming to COVAX, because there I think would be the interest for the audience, as well as a number of questions perhaps are referred to that. It is a facility which is a joint one by CEPI, Gavi, and WHO to ensure global equitable access to COVID-19 vaccines. And we have an ACT accelerator by WHO, which was launched by the DG of WHO. And COVAX is in the vaccines pillar of access to COVID-19 tools accelerator, which is, in short, we call it the ACT accelerator. It is a groundbreaking global collaboration of 3 major agencies, CEPI, Gavi, and WHO, to ensure and accelerate development, production, and equitable access to COVID-19 tests, COVID-19 treatments, and COVID-19 vaccines. What it offers, basically, there are 9 CEPI-supported candidate vaccines which are part of the COVAX, with a further 9 candidates under evaluation and discussions currently. There are already 80 countries which are self-financing, which have expressed an interest to COVAX of WHO, and 92 low and middle income economies are eligible to be supported by the COVAX Advanced Market Commitment. And the idea is that the doses through the COVAX facility are sent to about at least 20% of the country's populations which have joined COVAX facility. Vaccines are delivered as soon as possible. And we can basically look at the entire portfolio of vaccines, all the successful candidates together, and pool our resources together, synergize together. This is how COVAX is set up. As you can see here, development and manufacturing is led by CEPI and with pharma industry. The policy and allocation is with WHO, and procurement and delivery is led by Gavi. And there are working groups and individual teams in place to look at different aspects of COVAX, as you can see. These are the 3 work streams, but there are multiple sub work streams and teams which are looking at. And of course, the objective is, to have regulatory preparedness and product specific work to have synergized as well as streamlined work across the 3 agencies. There is a fair allocation mechanism for COVID-19 vaccines through the COVAX facility. This is the WHO document on that, and equitable distribution is the cornerstone of this document. And as Dr. Gupta had alluded earlier, the indicative target groups for vaccination suggested in the document are, again, the frontline workers in health and social care settings, people aged 65 years, and people who have, who are under 65 but have other associated comorbidities such as diabetes, hypertension, and other disease burden. They would also fall in this category. And as you can see on this one, the plan is to roll out the distribution of vaccines in 2 phases. The phase 1 is that all countries receive doses to cover at least 3% of their populations. And this is likely to focus on frontline workers in health and social care settings. And moving then to high-risk adults, all countries receiving additional doses to cover a total of 20% of their population. This would, of course, be done in tranches, and a buffer would also be set aside, to further add to the doses delivered in case of need as expressed by countries. This would then move to phase 2, where countries receive doses to cover more than 20% of their population. There's a lot to basically come in the next days and weeks, a lot of guidance and tools to assess countries' preparedness who have expressed an interest to join the COVAX facility of WHO, CEPI, and Gavi. And training packages are under preparation for health workers and national stakeholders. E-learning platforms would be utilized to deliver these trainings, national level trainings and sub-national level trainings, looking at various aspects, the distribution chain, the cold chain aspects, the logistics, etc. And in CRO region, basically, there is also regional working group with which the regional director has constituted, and there are meetings happening on a periodic basis with vaccine manufacturers and regulators. In July and August, there have been meetings and discussions which have been happening. There is also a vibrant information sharing platform among the 11 countries in the region on which regulatory updates are being shared. And this is a very recent release by WHO. It is a draft document considerations for assessment of COVID-19 vaccines. This is open for comments till 8th October. And this is basically providing guidance to manufacturers on the process and the criteria which WHO will deploy to evaluate COVID-19 vaccines for pre-qualification or emergency use listing. So emergency use listing is a procedure which has been opened by WHO for emergency listing of vaccines. We already know in India that a high-level national expert group has been set up. Niti Aayog member, Dr. Paul, and the Secretary, Ministry of Health are co-chairing the group, and all the various aspects, whether it's vaccine delivery, procurement, prioritization of the groups, logistics, all of them are being addressed. Of course, there are other members who you can see here, also part of the panel. And India, the DCGI has also, based on the guidance of US FDA and also the WHO guidance, the draft guidelines have been released by the DCGI and CDSCO for the development of COVID-19 vaccines. So this is already in the public domain. And I think India is going to play a key role, a very important role in the manufacture of and scale up of the vaccination agenda globally. And we have several examples, whether it's Serum Institute of India's signing the agreement with AstraZeneca for 200 million vaccines, or with Gavi. There are numerous examples, and I think the scale up is likely to continue. The plan for the COVAX facility is to deliver 2 billion doses of vaccines globally by 2021, end of 2021. So I'll stop here and look forward to the questions. We all need to work together, and thank you for your attention.
So thank you so very much, Dr. Madhur. This really, lays down the context of what efforts has been going behind the scenes by WHO. So our knowledge has always been the media related, or whatever we could see or hear from Dr. Tedros or our own very own scientist, Dr. Swaminathanji. I think, but it's good to hear from the India representative, the technical officer. So I just did a jot down of the numbers, since you were saying 3% of the world population. And I believe there are 170 odd countries which have joined the COVAX facility, which people are claiming to be 70% of the world's population. And if we do a quick number, it's around 200 million population is what you want to cover in the first. And there is already a commitment with Bill and Melinda Gates and the COVAX and SII of 200 million. There is another commitment with AstraZeneca to provide another 100 odd million before the end of the year to the COVAX kitty. So that takes it to still 300 million. So my question to you, Dr. Madhur, is, with every vaccine almost saying it has to be 2 doses. So if we want to cover this 3% of the population, which is our wish list, still needs minimum 400 million doses. So can we just say that by when do we see this 3% population getting covered? I know, I'm sure that we can't predict when the vaccine will start, but by when do you see it would be a great time where the countries can say that my healthcare workers will be protected? So is there a timeline which WHO is looking at?
Well, Not really, but the early 2021 is seen as the potential date of launches of all the major frontrunner vaccines, whether it's AstraZeneca's with Serum Institute or the Moderna one. And the logistics and scale up of production, a lot of groundwork in parallel would be happening till that time. Serum Institute is already producing, as we know, the vaccines. So preparing for the scale up. And having said that, but looking at the prioritization criteria, the high risk population, the under 65, and the people with comorbidities are going to be the first one to get it. So of course, countries have their sovereign powers to deploy who are the high risk groups in each country. But it will take, I think, some part of 2021 to reach the 3% population and then scaling up to 20% of population. And a lot also see the light of the day mid of 2021, global vaccines.
Great. So my next question to you, Dr. Madhur, is because you said phase 1 includes 2 parts. One is the 3% population, and we get a fair assessment that 400 million doses is what we will need. And I'm sure that we will cover it in the first quarter of, or probably maybe 4 months of the next year, 2021. But what about the 65 and the less than 65 with comorbidities? Because the plan, which is 1.2 billion, and as I said, 170 odd countries, that takes us to almost 5.6 billion population of the world. So, I mean, I don't see a chance of the normal healthy individual getting a vaccine probably early of 2022. Is that what WHO is thinking, or are there efforts to make sure that even that population can be escalated for early vaccination as well?
Well, you know, the COVAX facility vaccines, the 9 candidates and the additional 9 under consideration, okay, those are the ones, you know, which are going to be considered for scale up to countries, and 2 billion is the target by end of 2021. But in parallel, we see, for example, if we take the case of India, there are 3 front runners already, you know, for the vaccine. We have the Bharat Biotech and the Zykov, who are currently in phase 2 trials. Those vaccines might be around by the end of the year, early next year. Early next year is what the health minister has announced. So those are going to be in parallel, the vaccines to deploy by the national expert committees. So there would be some tranche coming from WHO side, but there would be also domestic tranches by the domestic vaccines or some other vaccines which are not in these 9, which can be through bilateral arrangements arranged by countries. So there could be several channels of vaccines moving to the country, either through WHO channel or through domestic channels, through other country channels. Russian vaccines is already entering clinical trials, and also manufacturing is going to happen in India. Certain part of that will be deployed in India if the clinical trials are successful. So
thank you so much for that clarity, because Dr. Madhur, one of the questions which I keep getting everywhere, even when I go for a morning walk, tika kab aayega? When is that tika expected?
But I would like to add here, Ajay, that we should also, while we are waiting for the vaccine, we have to not lose focus of the social vaccine, which is our masks, our social distancing, our
absolutely.
Those are really the social vaccines which can do a lot to protect.
No, absolutely, and that's the reason why I was drilling down on the numbers, is because 2 billion doses means 1 billion population. Still, there is 4.6 billion which may be left out. So it is not an easy way forward, and that's the message we need to pass on to everyone. So thank you for that clarity. And with that, now I look forward to one of our Indian stalwarts, entrepreneur and a great organization being headed by Mr. Murtaza Khorakiwala, sir. So I believe, sir, even you have a presentation to make. So probably let's start with that presentation. Chetan, could you put it up for us? And then, sir, I will come to you for some unique questions which I have for you, specially designed. So, Chetan, let's get the presentation, please.
Yeah, good afternoon to everyone. And it is a pleasure to be at the FICCI panel discussion. And a good afternoon to all the panelists.
Chetan, can we have the presentation, please?
So as I start, I think our involvement in the whole vaccine space started with I give a little bit of a background. With our engagement with the government of UK, we have a business in UK for the last 20 years. We are in UK, and we have a facility over there. We have a fill and finish facility, and we have been manufacturing in UK, and we are among the top 3 pharmaceutical companies in UK. So early in the year, sometime in March and April, when the government of UK was looking at a contract manufacturer, and they were scouting around in UK to secure the vaccine for their own population, they approached us, and that is where our engagement with the government started. They did the same level of due diligence they do. They assessed the facility, the capacities, the capabilities. And finally, when they zeroed down on us as the contract manufacturer for fill and finish, and that's how we were able to get engaged in the entire COVID vaccine initiative that is going on. And our learning and our understanding regarding the vaccine is basically out of that experience. And I think it has a lot also we can share in terms of what our thinking is, and what we have learned from the engagement, the way government of UK is looking at it, the way the Western world is looking at it, and how they're approaching the entire situation. It is a mammoth exercise and requires huge amount of effort. So I thought it may be interesting for everyone that if I share our experience and what is the learnings that we have from there, which probably we could consider or think about over here in our country. The next slide, please. Yeah, next slide. So very early on, I think we all now realize that it is the only way that we can work in this space is through collaboration. There is no one entity or there is no one organization that can create the solution necessary for immunizing such a large amount of population in an area so fast. There is a huge role that government has to play in terms of proactive initiatives, in terms of engaging with various universities, in terms of engaging with the industry. There is a role that non-profit organizations like the WHO and global collaborative organizations like CEPI and Gavi that Dr. Gupta mentioned earlier, they have an extremely important role to play in terms of making the vaccine available for the lower socioeconomic and lower economic countries. And universities, a lot of the research, real research that happens in the universities. And they play a very important role in developing the vaccine. Actually, a lot of the vaccine development that is really coming out is from these smaller biotech and universities. And finally, the industry has a very important role in taking that vaccine that is developed at the R&D level, at the lab level, scaling it up, doing the clinical trials, and getting it out there in the market. And therefore, it is a highly coordinated and a collaborative kind of an approach that is required. Government also has a very important role to play in terms of engaging with the developers, the manufacturers, and securing the vaccine and procuring it for its population and its masses. Next slide, please. And as I said, it is a very complex project management activity that is there. It is also requiring huge amount of effort in terms of multiple things are required to be done at the same time. And a number of things are done in parallel. In order to optimize time and to manage the risk also, one has to do a number of things at the same time. For example, in terms of development, how do you fast track the entire process of development so that you can get the vaccine faster to the masses? The second aspect is in terms of the capacity, the manufacturing, and the fill and finish capacity. I think we are about 7 to 8 billion people in the world, And if 2 doses are required, it is about 15 billion doses are required. And just to find that level of capacity in bulk manufacturing, in formulation, in in the number of glass vials that would be required, to that extent, the level of capacity required is huge. And most of these capacities probably are currently being used to manufacture other medicines and other products. And that level of free capacity is just not available today. Can we put up new capacity? Can we repurpose the manufacturing capacity from what we are doing today to something else and do it fast and quickly? So it requires huge level of coordination, planning, thinking, and also flexibility in adapting in this kind of situation. There's also a huge amount of investment, I think, that would be required in creating new capacity, because current capacity may not be able to be sufficient, and therefore new capacity has to be looked at. Supply chain is another area where some of these vaccines, which are RNA vaccines and require minus 80 degrees frozen transportation, requires that cold chain facility to be created and be transported at minus 80 degrees. And those kind of facilities may not be available on a large scale in most of the countries. And therefore, those kind of facilities have to be created and developed and deployed on a large scale. And for a country like India, which has 2.5 billion doses required, to make that kind of minus 80 degree logistic supply chain facilities available and deployed will be an enormous amount of task that is there. So the distribution of the vaccine will be another very important aspect. And going on to my last slide. So I think another important thing is managing risk and uncertainty. We know that as we have vaccines in clinical development, they're in phase 1, phase 2, phase 3. All the vaccines that are in development will not be successful. And generally, the success rate from phase 1 to phase 3 is about 20%. So for every 5 vaccines that are there in phase 1, what eventually may get approved is only 1 of them. So that creates another level of risk. And secondly, as was pointed out earlier by Dr. Gupta, and that some of these platforms that are being developed are all new platforms. Other than the adenovirus one, which is an earlier platform, the others are new platforms. So that further increases the uncertainty that is there and the risk in the whole activity. Therefore, a very different kind of financial risk management and a strategic approach is required to bring these vaccines to the people in the shortest possible time. And one has to look at this in a slightly different context. And therefore, there cannot be dependence on, for a country like India or for any country in the world, there cannot be dependence on any one product. Like, just to give you an example, in UK, they have tied up with 5 vaccine manufacturers and got the commitment to supply 60 million, 100 million doses for the UK population. Even though the population of UK is 60 million, they have got the same commitment from 5 different manufacturers because they don't know which of those 5 vaccines will work. Same way in the US. US has also tied up with 5 or 6 manufacturers and committed the volumes for the population, not knowing which one will work. So as a country, one of the things that one has to look at is, can we tie up with 5, 6 different vaccine developers or manufacturers and secure a commitment of a certain number of doses so that it can then be made available to the population in the shortest possible time, especially the high-risk population, which is generally about 20-30% of the total population. So one is getting access to multiple vaccine candidates. The second aspect in a de-risking and managing uncertainty that is there is there is a certain amount of an advance risk that has to be taken in manufacturing the vaccine and stockpiling it. Even before the full clinical trial is over and before the results are out, most of the manufacturing of the vaccine is being done before that. So today, as soon as your phase 3 results are out and the vaccine is approved, the product is available for distribution and vaccination to the population. So about 6 months before the final approval, manufacturing of these vaccines have been initiated, they are started, and the government is giving an advance commitment to the manufacturers and development for procuring the vaccine and securing it so that as an advance commitment and stockpiling the vaccine so to make it available to the population at the fastest possible time. So there are very different ways and new ways by which this situation is being addressed. It is very complex, requires innovative and a different way of thinking and managing the situation. And the greater part of us being over here in India is that we have the capacity, we are very good in manufacturing, and we have good capacity, and that creates a great advantage for us in terms of making it available for the government and for manufacturing of vaccines for the Indian population. And as Prime Minister Modi said, that we can also export it to other countries and other markets. So this has been a little our experience in vaccine, and I'm happy to take any questions that you may have.
Sure. So thank you so much, sir. The only question which, probably thank you for explaining us the UK deal. It's a brilliant. It's something which, I as an Indian citizen felt very proud when, our own manufacturers are actually going out and partnering with the UK government and the foreign government and actually delivering value. So my question to you, sir, would be, you did make a very relevant point that there will be a limited stock. And that's the reason probably risk-taking ability or stockpiling is needed. The other way around is to look at how do you tie up with vaccine developers and increase the capacity. So if I had to ask you, what are the top 3 areas which worked in your favor when you were striking this deal with the UK government? What would be the top 3 factors which actually made UK pick up only Wockhardt? So could you just explain those top 3 business critical points for all of us?
I think there, if I have to say, there were 3 things. One is quality. I think when we are making a vaccine, the first thing the government would like is that whatever is made, they are sure of the quality of the product and the quality of the final product that is delivered. Second is, I think, capability, whether the technical capability of the team and the facility and the technical capability, I think that is very important. And the third most important thing, I think, was speed of response. In a situation like this, it is extremely important to be engaged in a fast, responsive way. And over here, time is as important value proposition as any other value proposition. And the ability to do things fast and in a timely way also has a unique value in a situation like this. Other than the fact, obviously, of the capacity we had, it was available, and the kind of facility that we had, which was, we had a new line, a new facility in our manufacturing facility over there. Other than the fact, also, we have been in the UK for the last 25 years, and we are the number 2 or number 3 generic manufacturers supplying to the UK. So they have a history of us over the last 20 years. They have seen us delivering a product of good quality, and they have been happy with that. So the history and legacy also has a role to play.
Amazing. So there are a lot of things which need to be looked into when picking up such partners in the whole way. So moving forward, sir, one is what we have known about the UK deal. Are there any other areas of collaboration Wockhardt is currently working on for COVID?
So as I said, I think we are not a vaccine developer. We have a strength in terms of manufacturing and in terms of capacities. And we have both biotech facilities which can do bulk manufacturing in India, in our biotech park, which is in Aurangabad in Maharashtra. And we have fill and finish capacities also in India, but also we have in UK. And that is where our real strength is as a manufacturer. We are not in R&D and development of the vaccine. So anywhere where there can be an opportunity for us to collaborate in that aspect, we would be happy to do that. And we are in discussion and engaging the government as well as other entities where this kind of a capacity can be made of use and the vaccine can be produced so that it can be made available in the shortest possible time.
Amazing. Thank you, sir. Thank you so much. And I'll pick up one of the points which you said, speed of response. And with that speed of response, now I look on to my last panelist, Mr. Sharad Goswami. I think, Sharad, your CEO, Albert, just made an announcement. And I'm just looking at whether it weaves into the Trump election or not, but he has gone ahead and made it that the Pfizer vaccine can see light of day in October. So what are your thoughts there? Could you just share it with all of the group here?
Thank you, Ajay, and thank you, FICCI, for the opportunity. As you can imagine, obviously, a lot of organizations are very much invested and have been so in this research. Speaking to Pfizer, we were amongst the organizations that took the challenge up and started working on it. The current status is that we are well into phase 3 of the trials. More than 35,000 candidates have been recruited, and the trial is very much underway. Things are going very well so far. And you're right, what our CEO has said is that we are hoping to see a readout on the efficacy of the phase 3 trials. If you had asked me yesterday, I would have said in October. You're asking me today, so I'm very happy to say this month. And then should that be in the lines that we are all expecting it to be, then the next step obviously is to file for a regulatory approval. And then, if that goes the way that we hope that will go, then this could be a vaccine that will become available for use across the world. The other thing that, Ajay, since you said speed, which also Pfizer has announced, is that we are going to be able to produce 100 million doses within 2020. In fact, that manufacturing has already started. Some of us internally actually saw that video and we were just so proud of seeing that first manufacturing happening in our plant. So those doses are already being made. And I think the whole idea, as you can imagine, is that, if things go the way that they are being planned, and this is a very unusual way of doing things, you tend to do these things sequentially. Nobody could ever imagine that you would put 100 million doses into manufacturing while you are still in phase 3 of a trial, but then these are exceptional situations. So we've said 100 million doses in 2020, and then 1.3 billion doses in 2021 is what Pfizer has so far announced that we are going to be able to put out.
Amazing. Thank you, Sharath, for that response. And then that brings me to another question is, as you rightly said, not October, this month. When do you see it coming? This month in India?
So Ajay, first things first, I think every organization that's today working on a COVID-19 vaccine, every organization's vaccine is going to be a vaccine for the world. And I think that's the way everyone is approaching this. It's the same, with Pfizer. This vaccine, if it progresses the way we are all hoping and the way it seems to be, is going to be a vaccine that will be available this year for the world. Now, every country has its own vaccine strategy. The experts spoke about it. Dr. Y.K. Gupta spoke about it at length. Every country will have its own vaccine strategy. Every country will determine, how do you strategize and segment the population, the first wave, second wave, and so on. Do you deploy multiple vaccines at the same time, which, like Dr. Khurakiwala was saying, seems to be the right strategy to go with. So when does a vaccine become available in a country depends entirely on that country's strategy and how they want to proceed. Looking at the global vaccines that will become available, looks like very, very soon. And then the indigenous efforts that are also following suit. So to your question, when will the Pfizer vaccine become available in India? I think that will determine be determined entirely by the government of India's strategy on this.
No, fair point, Sharad, and well spoken about this particular question. So I know since we have been hearing him from all the panelists, be it Dr. Gupta or be it Dr. Wadhwa, Dr. Roy, and even Madhur Gupta, Dr. Madhur Gupta also touched base upon it, is this largely looks to be adult immunization vaccine to start with, to getting start with. And I can't think of a better company than yours, which has actually led quite a lot of research in the adult immunization space. So what are the challenges you foresee for us as a country? I mean, there are a few which has been explained, but are there any other insights which you would like to share with the group here?
Ajay, honestly, I would love to speak more about the opportunity than the challenge, and I'll tell you why. And this is something that I've been saying in any panel that I've been invited to speak at. Um, you know, hopefully this year or early next year or whenever that is going to be, people like you, me, all the other colleagues on this panel are all going to roll up our sleeves, and we are going to queue up in front of Dr. Wadhwa's clinic and other clinics like those, and we will be getting a shot. Now, in the history of our country and indeed in the history of the world, you've never had adult immunization in its true spirit the way you're going to have now. To me, it's a tremendous opportunity, because a few things have happened. And please give me a few minutes to kind of just explain this thought process a little more. We've always had this notion, deep-seated notion, that immunization is for children. A newborn is given certain shots and then you do the boosters. And by the time you're a young teenager, that's it. I mean, your immunization is over. The fact is that immunization, vaccination is one of the most powerful tools that are available today to public health practitioners, to medical practitioners, to governments as a way to mitigate disease. Now, until the time, unfortunately, that COVID-19 took the world over, few people knew about it and very few people actually went out and said, what are these vaccines that are available? What are the ways in which I can protect myself as an adult? What are the ways in which an elderly person who is very, very vulnerable to so many infectious diseases, can I protect my parents or my grandparents? People with comorbidities, diabetes, cardiovascular ailments, can they protect themselves from these infectious diseases and communicable diseases that they are 10, 20, 100 times more vulnerable to? Very few people knew about this. Very few people went and got that protection. What's going to happen now is truly adult immunization. So to me, it's a huge opportunity for all of us to put a spotlight on the fact that not just COVID-19, you have today vaccines available that can protect adults, elderly, patients with comorbidities from very serious and life-threatening diseases. So my hope really is that we are not going to stop at COVID-19, that we have kind of opened up a mindset. We've opened up an infrastructure. We've opened up a capability. And hopefully we've opened up the government's attention also to the fact that there is more we can do with adult immunization and bring down some of these mortality rates that are associated with adults, elderly, and comorbid patients from some of the very, very serious life-threatening diseases. And I'm sure Dr. Wadhwa can spell out which I can't. To me, therefore, Ajay, I mean, the challenge will solve itself out. I mean, India has a lot of experience with massive immunization programs. Our UIP is one of the largest in the world. So we have, experience of doing this. But to me, the opportunity really now is to say, how am I going to protect my elderly, my adults, my comorbid patients? Because adult immunization is not just COVID-19, but so much more.
So wisely spoken, Sharad, and thank you very much for those great insights. So now I will come to Dr. Y.K. Gupta, sir. Sir, if probably there's a lot which the panel has expressed. There is a lot about who the first line vaccinators could be possibly. I think Dr. Madhur has already spelled out what WHO thinks. Coming to a country like India, where health is still largely a state subject, and healthcare workers largely still are in the state government fold. So how does India plan? I know one of the things which probably comes to my mind is, do we have a database, or how do we distribute it between the center and the state? Because it looks like all the vaccination in the initial first few months, at least the first few, I would say 2 quarters, will largely be driven by central government. So are there any plans which ICMR or the government is thinking of how they plan to do this center and the state distribution of the vaccines they will be procuring?
Is a complex question, and my answer would be that I cannot answer this at the moment.
Okay, sir.
The government has several round of meetings on this and very intensely planning the strategy how to do that. Starting from the amount of the number of the vaccines which will be required for the country, B, how to strategize the vaccine to be given to the high risk population or the front health worker, how to strategize the transportation of that, because some of the vaccine, rather many of the vaccines will require cold chain, how to have the existing cold chain system which is already existing combined with that, and that's what the ministry has already worked out, roped into that system, because we have already very robust system of vaccine transportation for other vaccines. How can that be roped in? It will also require the extensive training to the healthcare professionals who are going to give the vaccines, particularly the vaccine handling, and also about AEFI, what happens after the vaccine, because that has to be absolutely networked. Secondly, the question which you have raised is about the central and the state is the health of the state subject. So definitely in initial stage, it has to be completely driven by the central government. But later when this things gets matured, then the state government have to take their load. And that is when the state government machinery is good enough, sufficient enough. We cannot take a chance with vaccine, because if because of some operational issue, something goes wrong, then the blame or the aspersion will be casted on the vaccine itself. That will be disastrous situation. A good vaccine may be paused or may be halted or may go into disrepute because of the faulty or maybe wrong process which has been followed. So therefore, correct process, correct transportation, correct storage, and this entire correct chain, it has to be very well maintained.
No,
It is also
absolutely.
discussed. It was also discussed that we will not be having one vaccine. We will be having different vaccines from different sources, and each vaccine may have its own specific requirement for storage and like that. Some vaccine may be requiring 80 minus, somebody may require only 4, and therefore this has to be. Similarly, the AEs or adverse event profile of different vaccine may be slightly different. It cannot be identical, and therefore the product brochure has to be very carefully evaluated, and accordingly the training has to be given for that. And I will respond to wonderful suggestion which has been given by recently. I will talk maybe when you having some question, I think.
Yes, sir. So one of the questions, exactly what you said, from the audience, I would just pick up one question. There are so many questions coming. Dr. Bhaya had actually asked this, exactly what you said. Wouldn't choice of vaccine and choice of target population be based on whether vaccine is effective or efficacious, which you rightly said, or both, and whether the vaccine cuts disease risk or transmission risk or both? So I think the way you said that the adverse events, because it's not only about giving the vaccine, it's also about the follow-up and how stringent the follow-up needs to be, this being a new platform. So that was one of the questions which came out on the panel, sir, from the audience as well. So I think, sir, then in that case, I would ask and move to Dr. Madhur Gupta. One of the question, Dr. Madhur, is something which most of the things which, I have been in my discussion coming time and again is, COVAX is the facility you rightly said 9 vaccine candidates, then maybe another 9 which is being talking to. And it's not necessary that all of them are doing trials across this 170 countries. They may be doing phase 3 in a few particular group of countries. So has there been any discussion at the WHO level that what happens to these 18 candidates? Will they get emergency use authorization or an automatic route of approval just because countries have signed to COVAX and these guys are donating in COVAX or supplying to COVAX?
Yeah, so WHO has been engaged in discussions with the regulatory networks of ICMRA, which is a medicines regulatory network, with very active, also with the PAHO region, the Americas, and the Southeast Asia regulatory network. And there is a consensus that the emergency use listing procedure, which WHO has already notified, that could be utilized to pre-qualify the vaccines which are going to be there in the COVAX facility. But it's going to be, the discussions with the COVAX countries and the respective regulators are still ongoing and happening. Some of the countries, such as India, have already notified their guidelines and their expectations of the COVID-19 vaccines, which are similar as per the international standards. But some of the countries have not. So some of these regulatory pathways are still to be, are still being looked at to be by the headquarters of WHO. How the regulators will accept the vaccines through the COVAX, because it's going to be a WHO pre-qualified vaccine. The contract which is getting signed by COVAX with the country, the discussions are still underway regarding regulatory expectations and acceptance by countries. So I think some of the role networks will play a role, which are going to facilitate this process for the countries, but a lot is still in the works in the process.
Sure. Thank you, Dr. Madhur. And the same question then to Dr. Khorakiwala, sir. Do you see this as a challenge, because the regulatory approvals, because I see your UK facility going the fill and finish with UK government. You mentioned about your Aurangabad facility. Do you see these approval challenges which could be an hindrance for someone to come and pick up the facility or use this facility to mass produce for any other part of the world?
I think, Ajay, you raise a very valid point. And I think this is an area that requires, is evolving in its own way. And I think things are not very clear. But there is if you go as per the current guideline, whichever facility, the vaccine is considered to be a biotechnology product. So whichever facility one does the clinical trial and gets an approval, generally from that same facility, you have to manufacture the product for commercialization. Now, if the same guideline is applied in vaccine, I don't know whether that will allow for a rapid scale up of manufacturing capacities for manufacturing the vaccine and making it available in various markets fast enough. Because if the commercialized manufacturing site needs to be used for getting clinical approval, and then every time you change a site or add a site for manufacturing the product, and you have to redo the entire process, which today is the guideline for biotech product, whether that will be enough for achieving the objective that we need to immunize our population at the fastest possible speed, that would not be possible. And therefore, there may be some need to relook at that and see how it can be, that risk can be managed better and faster.
Thank you so much, sir, because that's something which I wanted to hear from an entrepreneurial organization like yours, someone who's really built the business from scratch. And I think this is a question which should be there as one of the recommendation from FICCI to the, I would say, WHO, Indian government, because as rightly said, we may have the capacity, but if the regulatory hurdles exist, the mass immunization program, as I said, the numbers I've already proven, the numbers of 2 billion is also less, because if we are talking about mass immunization of 5 billion population, that's almost 10 billion doses with all the cold chain, with all the adult immunization, with everything, best of the best getting provided. So that's something which, we all have to think together. So with that, I would, being mindful of time, we just left 10 minutes now and the clock's ticking. So I want to collect a closing feedback from everyone. So I'll just reverse a little bit of the order. So let me go with, because the session was about COVID vaccine and are we there yet? And definitely from whatever the discussion I've heard, we are still not there yet. And we may not even cross that line in 2021. So maybe I'll start with Dr. Avilaral Roy first. So maybe your closing remarks from this panel, please, sir.
So I guess my closing remarks to everybody would be, the vaccine is coming, right? Whether late 2020 or early 21, the vaccine's coming, but deployment will take time. Does efficacy is still unknown. So it's still very important for all of us to follow best practices, social distancing, using masks, hand hygiene. These have to be the cornerstone of our therapy till we figure out, and there are a lot of my panelists and co-panelists far smarter than me, can figure out what is the appropriate rollout for the vaccine, who gets it first, how do we manufacture it. But at the ground level, it still has to be, don't let go of all the gains we have made by forgetting everything and going back to status quo. We have to consolidate the gains made till the vaccine can hit the doorstep and we have effective distribution and delivery system.
Amazing. Thank you. Thank you, Dr. Roy. Dr. Wadhwa?
Yes. So you asked me where, you were asking where about the finishing line. So I have personally a different opinion to that. The finishing line will not be the manufacture of the vaccine. The finishing line will be when the whole population of the world, if not the whole, at least 60-70% gets it. So that finishing line is way far off, actually. And as I see, there'll be two different kinds of vaccines. One will be these adenovirus RNA vaccines, which will work only for probably 1 or 2 years. And if we want long-term acting vaccine, we'll have to have what we have now, the whole cell vaccine, either the kill vaccine or the live vaccine. And if you ask me, my dream would be to have a live attenuated vaccine, which is given by a nasal spray. So it's easy to give, it's easy to administer, and live vaccines work very well in terms of immunity. And when you give by a nasal spray, it gives you local immunity also, and it helps in prevention of transmission also. So that would be the ideal thing, that at least you're not transmitting to others also. So that, and unfortunately, the live vaccines take the longest to make, longest to study, because live means the virus might activate inside you and actually produce the disease. So if the RNA adenovirus take 2 to 3 years, 5 years, attenuated will take 5 to 8 years, live will take probably 8 years to 10 years to be coming to the market. But I'm very happy to see that there are already 3-4 live nasal spray vaccines, and even Bharat Biotech has just now tied up with Washington University. There's another core flu vaccine they're trying, the influenza vaccine based coronavirus vaccine, which will be given like a drop. Chinese are also trying one nasal spray vaccine. So if that comes, that will be a real dream. Till then, of course, mask is the only vaccine.
So true, Dr. Wadhwa. So maybe I'll now direct to Sharad. Sharad, your closing remarks, please.
Yeah, so you asked the question, are we there yet? COVID-19 vaccine, are we there yet?
You said this month.
Pfizer's response is, if things go the way that they're going today, we will have an answer this month. Amazing. As far as Pfizer is concerned. And then like Dr. Wadhwa said, that is then going to be the starting point of what needs to happen next. Countries need to have their strategy in place of how they're going to use these tools that our companies are going to be able to put out and deploy them, and who are they going to protect first, and then how does that get phased out. And then to me, it's not the finishing line, Ajay, at the risk of repeating myself, it's the starting line of saying, this wonderful tool that we have always had at our disposal finally will get its due share of credit and limelight. This beautiful tool called vaccine. How are we going to use all these vaccines that have always been at our disposal to go out and save lives? So answer this month from Pfizer, and then
maybe just
that's
to
the
add
starting
that, till
point.
we have a vaccine, at least take the vaccines which are available already, like the pneumonia vaccine. At least take that before the coronavirus comes. The flu vaccine.
Okay. The flu vaccine. Amazing.
At least whatever, take that.
Sure. So Dr. Khorakiwala?
Well, I think a lot has already been said, and we have a long way to go. We are actually at the beginning of the journey till we all get immunized and protected. And I don't know whether one season is enough, or whether this is something that will need to be done on a regular basis, year after year or season after season. So it is a new phase of life, but I think we are all doing a lot, and I'm sure that all the energies in multiple areas with all our expertise, as we are putting it together, something good will come out, and hopefully we'll be able to be safer and healthier. And we take back some lessons, I think lessons of life and lessons of the way we are living. I think there are some very deeper lessons that we can learn out of this entire experience. One of the things that I believe is that we can be far more happier with less than what we have. We thought that to be happy, we need a lot. But today, I feel that with a lot less, we can be as happy, if not even more happy. So I'm sure that we all will take back some unique lessons from this experience and grow wiser and happier also at that.
No,
May not be richer, but happier.
No, I appreciate those words of wisdom, sir. Actually, very nicely articulated. So thank you for those words. Dr. Madhur Gupta?
I echo the same sentiments as Dr. Khurakiwala very well said. The COVID pandemic, will change the entire landscape of how businesses are going to be run, and the entire, online system of meetings and the face-to-face presence in offices, getting, either reduced or not there. So it will exactly change the way the entire world is running and will run in the future. Regarding the vaccine, I think there's going to be a huge marathon even after the vaccines hit the market, to continue to look for their efficacy and their safety primarily. The Global Vaccine Safety Committee of WHO has outlined very clearly certain adverse events with specific vaccines, which are the adverse events of special interest, which need to be followed up very rigorously in the health system at the various level of facilities after the vaccines are given out, to actually collate the data on safety as the vaccines are being given out. But one good thing that has come out for India from the pandemic and from this vaccine development story is that all the players have come together, and the agenda is actually highlighted and gotten its due importance at the level of Prime Minister. So much so that this was the only point from India, the manufacturing or pharma sector, which was highlighted in the UN General Assembly by the Prime Minister, that India is a vaccine manufacturing hub and we are going to, export it to the other countries. So that's really very heartening.
So true, and I agree that the Prime Minister getting the importance of the world stage. That's something, boasts a lot about us to be pride for Indians as Indians. So maybe Dr. Y.K. Gupta sir, your last words, sir, on this panel.
Thank you very much. And before I say something, I may not get an opportunity. So I must thank wonderful and I would say extraordinary comments by Sharad, my old friend, Madhur, very dear, and Dr. Khurakiwala. Nice to see you here, Dr. Khurakiwala.
Thank you. Nice seeing you, sir.
Arun and Aviral, and of course, very dynamic our coordinator Ajay. I think what we have seen is the coronavirus story started with the tragedy. Then there was intense science into it, and what we have seen today, particularly Madhur and Sharad, and also Dr. Khurakiwala, they turned philosophical. And this has changed the entire economics also of the country, the management, and also if you see the new normals have come in. So this is entirely different issue. And I wish that what you are looking for, the spectrum of vaccine preventable diseases is expanding. Initially, we used to say, what are the vaccines preventable diseases, 1, 2, 3, 4. But now vaccine preventable diseases, including coronary artery disease, cancer, say now tomorrow you may say the sadness, or maybe you say the depression, and ultimately vaccine against death. That is the ultimate the ultimate philosophy of that. So the most important thing is what all you have said and nothing more, but let us not forget that corona is not the end of the disease. The virus may spread, mutation may change, and maybe there may be more disease which are already, the information is coming up. So therefore the platform technology of developing fast, effective, and technology to test the safety without going into the massive time consuming PSUR safety update report, or maybe the PMS. There should be artificial intelligence used to test that what will be the predictability of the safety and the safety efficacy of this. That is what people are working together today. And that would be more important for tomorrow. And also important thing would be that can we have least number of vaccines for the maximum number of the diseases. That means can we put in one vaccine capsule or injection couple of diseases which are impregnated into that, and that is what also being tried into. And maybe that may be the future when our children will become old, that will be the future of the vaccines. So I thank you everybody, and wonderful discussion, and I wish that this was more than 4 hours, but in 2 hours I think Ajay you did a commendable job. So thank you very much.
No, sir, I think I did a commendable job just because the panelist is such commendable. Otherwise, I wouldn't have been of any impact. So I really, because I have to tell you, Dr. Gupta, with you, sir, leading all of the vaccine efforts with Dr. V.K. Paul, I am dead sure the meticulous planning which you have briefed us, you have just given us a strategic input of what is the government is doing. And we believe there could be none better leaders like you, Dr. Paul, leading this effort for us and making sure and keeping ourselves or keeping India safe. And we really look forward to you getting that plan up and rolling. And as thank you to all my panelists, agree that this is not a finishing line, this is just a starting line. And we are happy to embark on a journey with all of you together with us. So thank you, sir. And thank you, my esteemed panelists. Thank you very much.
Thank you.
Thank you very much.
Thank you.
Pleasure.
Bye-bye.